Hello and welcome to the Viz Expert Series. We're thrilled to be launching this new interview series where we'll be diving into fascinating topics, including artificial intelligence in healthcare, a space where innovation is rapidly transforming the lives of both patients and providers. Throughout this series, we'll be speaking to leading clinical experts, discussing both the trials and tribulations of AI, but also discussing where it should be applied and where it might not be applied. My name is Jack Manley. I'm a British trained doctor by background, but in my current capacity, I lead product strategy for Viz.ai. Viz.ai is a software company that has established itself as a leader in developing AI-enabled care pathways. We build AI products across a wide range of therapeutic areas to help clinicians perform at the top of their license. Our North Star is to get more patients access to life-saving treatments. Today, we're honored to have Dr. Jorge Nieva with us for our inaugural podcast. Dr. Nieva is a renowned oncologist and researcher from the University of Southern California, specializing in both lung cancer and head and neck cancers. Throughout his career, he's been at the forefront of advancements in cancer detection and personalized medicine. As a technologist and a true leader in his respective field, Dr. Nieva is the perfect guest to help us unpack the current and future role of AI in oncology. In this conversation, we'll be leaning heavily on Dr. Nieva's expertise in lung cancer, the leading cause of cancer death in the US, and unsurprisingly, an area of interest for AI-driven technologies. So without further ado, let's jump into the conversation with Dr. Jorge Nieva. Dr. Nieva, how are you doing today?
I'm doing great, Dr. Manley. Thank you so very much for the opportunity to speak to your audience. Very excited to be here today to discuss innovations in artificial intelligence.
Fantastic. Well, we're very lucky to have you. And to start off with, I'd love to get a bit more information about your journey in medicine and what drew you to oncology and specifically lung cancer.
Well, I think it was as a medical student when I first started having contact with cancer patients. And what I really loved about oncology was just how engaged the patients were and just how interested they were in their own health and trying to maximize their own health. There's a lot of fields in medicine where you feel like, you have to nag the patients to take their insulin or lose weight or exercise. And you don't have to do that with oncology patients. They're just so very engaged and interested. And we can have such very high-level discussions with them about complex topics. It really is the patients that brought me to it.
Gotcha. Well, that's very, very inspiring. And, we'll definitely get on to that engagement as both an opportunity, but also a challenge shortly in the conversation. But I want to reflect on your career. When I was reading, your background, I noticed that it's been incredibly diverse. You've pioneered cancer cell detection technologies. You've led clinical trials. You've done a lot of different things. But my question is really how those experiences have actually shaped your role of technology in advancing cancer care.
Well, it's always started as a clinician, but my first real foray into research as an oncologist, I had to work driving a mass spectrometer and a high-pressure liquid chromatograph, looking for various analytes present in people with various diseases. And so early on, I developed a need to really understand analytical technologies. And I think that's what really got me started in technology and got me interested in really assays and their ability to predict the future. Because one of the things that cancer patients really suffer from is needing information about their prognosis. I think cancer, more so than most other diseases, has this feature of uncertainty about it. And so trying to get more certainty about what's going to happen and what the future holds, I think is tremendously important for patients. So that then led me to work with a variety of other investigators, Peter Kuhn and others, to develop better technologies for predicting what will happen in the future. And so we developed liquid biopsy technologies, trying to find cancer cells in the circulation of patients. Of course, finding those cells is bad, and patients typically do worse when we find more of those cells. But those cells are also wonderful opportunities to gain diagnostic information about the cancer. So many of our cancers now are treated on the basis of molecular signatures. So being able to interrogate cells in the circulation has been tremendously important. That then has moved on to technologies around cancer DNA detection in the bloodstream. And that also provides our patients with that prognostic data that they really are seeking. But of course, the best predictor of how patients are going to do is oftentimes people's own eyeballs, right?
Hmm.
I used to joke with technologists, and they said, "Well, Dr. Nieva, how do you know how well a cancer patient's going to do when they come to see you?" And I say, "Well, it's pretty quickly. I look at them as they're walking in from the parking lot, and if they're having an easy time walking, they're going to do better than if they're having a hard time walking. You don't need to be a physician. You can be the door greeter, and you'll actually have a pretty good sense of what's going on." And so that actually led us to actually quantify that information. So we developed technology using digital cameras, three-dimensional cameras, and wearable sensors to really put quantitative metrics on how patients are moving. Because to be honest, I get much more information from just watching the patient move from the chair and get onto the exam table during an office visit than I get from using my stethoscope or any of the other tools of physical examination. But my eyes and your eyes and someone else's eyes might be different. So we wanted to develop digital tools around actually measuring that movement. So we did that. So for me, my career trajectory really has always been about understanding prognosis, understanding diagnosis, and trying to use the most advanced technologies of the day to try to get at those two pieces of information.
That makes a lot of sense, and it's a beautiful segue into AI. AI obviously being a buzzword, but of course the pivotal technology and probably the best technology to spot patterns from large quantities of data. But of course, its impact varies by specialty, and I guess from your perspective, what excites you the most about AI's potential in oncology today? And are there areas where you're already seeing it make a difference?
Well, I think there's a number of areas where it really is making a difference. And AI for me really is a tool. It's a tool that helps humans. It helps us be more efficient. It helps us be more accurate, and it helps us keep from missing things. So, for example, the previous technology that I mentioned, using a digital camera and having AI give us measurements about velocity at which a human body is moving and calculations of acceleration. That tells us what the patient's performance status is on an objective basis and can give us a sense as to whether or not the patient's going to tolerate very difficult treatments. Other places that AI is being used is in pathology. We use it to determine what's the likelihood that the patient's going to have particular genetic mutations. There's companies out there trying to go from just a visual image of looking at cells under the microscope to an AI prediction of what the molecular structure is going to be that's really driving the cancer. We also want to be able to use AI tools for other things, like knowing whether or not a patient's going to do well with a cancer treatment, do poorly with a cancer treatment. When is it that they're going to need to think about hospice care? And trying to build metrics around these sorts of things. Many of these things are not yet ready for prime time, but many of them are. Viz.ai is pioneering technology now around nodule detection and identifying pulmonary nodules. And that's really important, not just around diagnosing them, but about simply capturing events and making sure that they're not being missed, and then putting them into separate workflows so that clinicians can make sure that people aren't falling through the cracks. And I think AI can be very helpful in making sure that we're not leaving anybody behind and we're capturing all the events that we need to capture.
Yeah, that final point resonates with me deeply. Coordinating across diverse specialties for patients is incredibly challenging. The knowledge is ever expanding, and there's real data out there that suggests that these patients are falling through the cracks. I mean, you mentioned incidental pulmonary nodules. When I think about the studies on IPN specifically, you know, about a third of patients currently receive that follow-up care for nodules. And so I think to your point, AI is perfectly positioned there to flag, to match what has actually happened to those patients and flag the ones who haven't received guideline concordant follow-up. I'm curious though, in your practice, like what do you see as the biggest barriers to ensuring those patients actually get the guideline directed follow-up? Why do you think they are actually falling off the radar?
Oh, we have a tremendously fragmented healthcare system in the United States. And I don't know if the UK is having similar issues, but um, you know, the system doesn't provide for, good easy access to primary care physicians, frequent access to primary care physicians. And oftentimes emergency care is done by someone else, hospital care is done by somebody else. We've separated inpatient care from outpatient care in the United States as an artifact of kind of how medical billing occurs. Uh,
Mm,
and in many ways, it's built some efficiencies, but in many ways, it's also caused patients to lose the connection with their primary care physician when they're hospitalized. And because we have such a focus on specialization in the United States, many patients are getting this very high-tech specialty care, um, but that oftentimes means that everything is compartmentalized.
mm,
I every once in a while am asked by lawyers to comment on medical malpractice cases, and the most common case I'm asked to comment on is a misdiagnosis of lung cancer. It's someone who showed up into the emergency room because they had a broken leg, because they had abdominal pain, or because they had some other issue, and they had a CT scan done, and there was a pulmonary nodule on that CT scan. And then maybe they faxed that report to the primary care physician. Maybe the radiologist flagged it for them, or maybe they didn't. And then later on, a year or two later, that pulmonary nodule ended up being a lung cancer in advanced stage, and there really just is no defense for that. From a medical legal standpoint, the clinicians involved typically end up having to settle these cases because there's one of those things where people say, well, there's just no excuse. Well, the excuse, of course, is that we're doing a lot of other things and we're paying attention to other things. And the emergency room doctor was worried about the broken leg, and the orthopedic surgeon was worried about the operation. And the fact that there was a small pulmonary nodule is something that, at the time seemed inconsequential, but later on in the patient's life, it was actually the most consequential thing that was going on in the visit, but we don't actually know that that was the case at the time. So many pulmonary nodules end up being nothing, but they all need follow-up. And so one of the things that's exciting about these types of technologies that find nodules and record them is actually their ability to then generate a work list for a dedicated clinician whose job it is to work the list and make
yeah,
sure that the patient's actually getting the follow-up that they need, and that these little events, which for the vast majority of patients, are going to be inconsequential, uh, um, uh, don't get missed for that 1-2% of patients for whom that was their opportunity to be cured of a disease that, if missed, they weren't going to be cured of.
absolutely. Yeah. Well, one thing actually that stands out from what you're just saying is clinical capacity. You mentioned a dedicated uh, clinical person managing that list. Like, how does that look like? What does that look like? Sorry, from a clinical capacity standpoint, are systems and providers investing in this today? Is this sort of top of mind for them, or is this another capacity strain that they don't see value?
Oh, no, I think they see tremendous value. these we have a fairly litigious system here in the United States with medical lawsuits, and it only takes a couple of multi-million-dollar judgments to get people's attentions on missed nodules. The advantage to AI is that you can generate these lists and then put it in the hands of someone who, doesn't necessarily need to be a physician. That can be a nurse clinician doing it, a care navigator, someone like that, who for the health system then also actually becomes a revenue generating person, because they then direct the follow-up scans and the follow-up care to stay, within the system that identified the nodule in the first place. So we here in Los Angeles, we're tremendously competitive in the healthcare arena. We want our patients at USC to get their follow-up care at USC. We don't want them to get their follow-up care at Cedars-Sinai or UCLA, of all things. So when we identify these pulmonary nodules at USC, we want to make sure that the patient then is continuing to get follow-up care at USC. And I think the business people really understand the case for that. They don't want the patients to necessarily be followed in another system, and they certainly don't want the worst thing to happen, which is that the patient's not followed at all, which unfortunately is really the worst outcome possible.
No, that makes total sense to me. And it's also, again, it sort of resonates with us at Viz. We see the value beyond the physician. We want to enable the broader healthcare team to have access to these AI tools, because, a lot of the capacity challenges that do exist in the system you can actually solve them, or, indirectly contribute to solving them by empowering other members of the clinical care team to be able to take action in a guideline concordant fashion. I'm curious on other sort of skepticism, other issues with potential adoption of these novel technologies. From your perspective, what other skepticism do you see around the adoption of software solutions like nodule follow-up? And how might these solutions essentially build trust within the system to avoid that?
Oh, well, I think it's always about who's going to pay the bills, right, in healthcare systems. So I don't think it's so much an issue of skepticism, as much as it is an issue of, does the money that this is going to cost come out of my silo, and is all the revenue going to end up in somebody else's silo, which I think is one of the short-sighted things that happens a lot of times in organizations that have very focused management, where oftentimes we'll think about our own economic unit within a healthcare organization and not think about the larger strategic value to the whole organization. We see that balkanization a lot. But I don't think there's any question that these programs work, that they identify nodules. I don't think there's any questions that they can generate work lists. I think there may be skepticism that can we really follow things up? Can we actually work a work list? Can we do it effectively? Can we make sure that the patients actually stay within our system? And can we do that all in a way that is satisfactory to patients? So I don't know that it's so much of a reluctance to use technology. I think it's more a concern that we won't operationally be able to do this well, do this efficiently, and do this in a way that's satisfying to our patients and, frankly, to the bottom line of the healthcare system.
That's very insightful, and a lot of cynicism from my side, across the Atlantic, but it's an eye opener for sure. I wanted to move on. I wanted to start talking. We've spent some time talking about the top of the funnel, nodule detection, nodule perhaps like risk stratification, and nodule follow-up. And perhaps it's the follow-up that's actually really where the low-hanging fruit is. But I wanted to move on into personalized medicine. We now know that I think there are over 30, last time I checked, 30 targeted therapies for lung cancer alone. And molecular testing, as you highlighted right at the start of your introduction, is central now to treatment decisions. So I was wondering, to start us off, could you walk us through a typical testing workflow for a lung cancer patient today?
Of course. So we'll typically see a patient and they'll have some kind of a mass in the lung. And the first thing we'll say is, well, this mass needs to be biopsied. And so the first question might be, well, how to biopsy it? And turns out that decision actually matters. If you biopsy it with a bronchoscope, you actually are going to be much more successful at getting sequencing data later than if you biopsy it through a fine needle. We did a study showing that needle gauges of 21 or smaller are not very good at getting next generation sequencing data out of the lung. So the first thing, of course, is to make sure that you're doing the right biopsy and you're doing a large enough biopsy. Once we've established a diagnosis of non-small cell lung cancer pathologically, the next step is typically to send the material for next generation sequencing. And that can happen off the tissue. It can also happen from blood. And whether or not you do one or whether you do both, for us at USC is largely dependent on how good that biopsy was. If it's a fantastic biopsy, a forceps biopsy of a central airway mass, well, then we can just send tissue. If it's a fine needle aspiration biopsy done transthoracically, well, then we should probably do blood also. And if the patient had the biopsy done previously at an outside hospital in Timbuktu, that's going to be very hard to get tissue to move out of, we may just do blood in that case. So we will want to be sure to get the best next generation sequencing we can. That then takes 2 weeks to get sequencing data.
And is that 2 weeks? Is that sort of USC as a leading cancer center, or would you say 2 weeks is sort of the average?
Two weeks is the industry minimum. We use one of the largest next generation sequencing providers in the country. And when I first sent a specimen to them, they got back to me in longer than 2 weeks, and I told them, this is completely unacceptable. And so to their credit, and this was at the time, this was Keras, to their credit, they recognize that lung cancer is unique in that we don't do first line therapy without sequencing data. Many other cancers, the sequencing information, that can all come later because first line therapy is not dependent on sequencing. But in lung cancer, it absolutely is. So to their credit, Keras adjusted their workflows, got people to work on weekends. But you can't make DNA amplification happen faster. You can't make microdissection happen faster. There are some physics limitations on how fast sequencing can occur. So that 2 weeks becomes excruciatingly difficult for patients and really has tremendous downstream implications as well, because you can imagine that if you're a lung cancer patient and you find out that you have advanced disease and you get told, yeah, you have lung cancer and your lung cancer is in stage 4, and now we're going to send sequencing information on you. And then you come back 2 weeks later, you're at the edge of your seat and wanting to know what your sequencing data was so that you can be started on treatment immediately. And can you imagine the situations where the doctor then wants to say, oh, well, your sequencing information shows you have a mutation in EGFR. Oh, and here's a clinical trial that we can do, and we can get our clinical trial started in 2 to 3 weeks. The patients, can't imagine having another delay after that 2 week period of time. So it does impact first line therapy clinical trials in the US. But that's unfortunately, that's the workflow. That we get the sequencing information, and before the sequencing information is out, we don't know what the first line of therapy is going to be for them.
That is I can only imagine, a very challenging conversation that you need to have with a patient who's obviously wants to get started ASAP. You're having to wait. And I'm curious, there are some technologies that are looking to solve this. And I was wondering, how do you feel? Do you feel like AI could potentially address some of these challenges?
I think potentially, yes. One might imagine that if AI could predict probability of a mutation occurring, maybe we would funnel off some of the patients to get kind of more rapid single gene testing. Um, uh, and one could imagine that you could also get that from radiologic information. You can get that from demographic information. Uh, I mean, you can, every single thing about the patients, of course, is a probability variable. And this is what AI is very good at. For example, if I say to you, well, I'm seeing a patient and they're an American and they are being treated for lung cancer. And you say, well, what's the probability that there's an EGFR mutation? And the answer would be, oh, about 15 to 20%. And then I say, well, okay, now the patient's Latino. What's the probability? And the probability now is 25%. And then I say, it's a Peruvian Latino. Well, now it's 50%. I
Yeah.
say, oh, no, I take it back. It was an Argentinian Latino. Oh, no, no, no. Well, now it goes back down to 21%. All these factors end up being probabilities. And then you say, oh, well, what if I told you that the patient has brain metastases? Well, now it's more likely to be EGFR positive.
Yeah.
And you say, well, what if I told you that it was a miliary pattern on the radiograph of the chest? So, now again, more likely to be EGFR positive. So one can imagine that based on age, sex, race, radiologic appearance, pathological features, you can build these Bayesian probability analyses, using neural networks or using other forms of probability estimates. Um, and get a sense of, well, what's the likelihood that we're going to be in situation X and what's the likelihood we're going to be in situation Y? And then you can start to build workflows where you say, oh, well, if the probability is high enough, then maybe we need to do some rapid single gene testing. Knowing that if we do that, we're going to eat the cost of it. But then maybe we either don't need to do next generation sequencing or more likely, we're still going to have to do next generation sequencing, but maybe we can start thinking about starting therapy before that comes back.
Absolutely. Yeah, no, I think that's incredibly interesting. I was reading a number of research reports, and it still seems like in the US that about 40% of patients who have dual PD-L1 and EGFR expressing lung cancers, that patients are still being treated with immunotherapies like the Keytrudas of this world, rather than waiting and being put on the correct targeted therapies. And so I think this is, to your point, I think this is an area ripe for disruption, and an area that we, as an AI company, we are incredibly interested in, specifically the radiogenomics as an exciting frontier. And so I'm curious in terms of your understanding of radiogenomics and potentially its ability to 5, 6, 7-fold increase that baseline probability that you have from perhaps just looking at someone's ethnicity. How does that sort of practically change your practice? Does that give you, as a clinician, additional confidence, when you might be under pressure to start therapy with, during these difficult conversations? Do you think this is a helpful adjunct?
Well, Dr. Manley, you bring up an excellent point here, and that is that the order in which information arrives is critically important. So the reason so many people with EGFR mutations get treated with checkpoint inhibitor therapy is, of course, that the checkpoint inhibitor biomarker comes back first.
Right.
And the EGFR data comes back later. And so one of the great things about radiogenomics is that radiographic information actually oftentimes comes back before we have a cancer diagnosis, before we have any pathology at all. And that really lets us modify our approach, modify our Bayesian probability analysis, and then tell some patients to have an altered workflow on the basis of it. I still remember a time, it was many years ago, and a patient comes in and he says, my radiologist says, oh, this pattern that I see here, this is almost certainly an EGFR mutation. And at first I was incredulous. I'm like, you can't tell that from a radiograph. You can't see the genes. And then lo and behold, you do some reading and you said, oh no, that's exactly what that is. This pattern is typical. And so I think artificial intelligence is great. I think human intelligence is pretty great too, when it can identify these patterns. But the great thing about artificial intelligence is it really levels the playing field. You don't have to be the world's greatest radiologist if you have an AI machine working with you that can give you the information that the world's greatest radiologist would also have. And that's one of the great things about technology is it really does make everybody an expert. And that's something that we all could use a little bit more of.
Absolutely. Absolutely. And I love the framing of, reorganizing the time in which information arrives. If the guidelines are suggesting that you wait, then if you could reorganize and have the targeted radiogenomics come back before the immunohistochemistry results, that could be huge in terms of guideline concordant care and making sure that these patients get on those targeted therapies. So I really like that framing. I did want to move on, though. I wanted to move on to care coordination. This is something that is incredibly close to our hearts at Viz. We started as a stroke company, and care coordination was one of the leading challenges that we saw in the stroke workflow at the time. But I'm curious, in lung cancer specifically, we know that multiple specialties are involved. You have the radiologist, you have the pulmonologist, you have the medical oncologist, and then you might even have radiation as well. I'm just wondering, like, what are your thoughts on how AI can improve both the communication and coordination across these teams to ensure that patients get that seamless care that we are all striving to deliver?
Well, I think that one of the things that we like in multidisciplinary care teams is for people to be predictable. Um, I work in a very tight multidisciplinary team, and most of the time, I know what my surgeon's going to say on a case before the surgeon actually says it. And that's because I've worked with that surgeon for a long time. And I know his patterns and I know what he'll operate on and what he won't operate on. And the same is true with our radiation colleagues. So forming those type teams is very helpful. Now, pick me up and move me to another hospital. I haven't the faintest idea what the surgeon's going to say. I don't know what types of tumors they want to operate on. I don't know what my radiation oncologist's comfort is with radiating lesions with SBRT that are close to the central airways. And so here again is really one of the great potentials for AI from the standpoint of workflows is that it can provide a level of standardization and predictability across different fields and across people that are having to work in unique environments. So, for example, if my AI probability tool is one that's being used nationwide, and it lets me know whether or not someone is likely to benefit from an immunotherapy or likely to benefit from surgery for patients with single station N2 mediastinal involved lung cancer, or whether or not a lesion has a high or low probability of having a complication with SBRT. I think these are tremendously good tools for people to have available in a standardized fashion. It's also tremendously helpful from the standpoint of communicating with the patients.
Yeah.
You know, it's one thing to say to a patient, I think there's a good chance we can resect this. It's quite another thing to say to a patient, there's a 73.2% chance that we can resect this. One gives the patient a greater confidence, and one lets you know that you're dealing not just with the opinion of one human, we're all fallible, but you're
Right.
dealing with aggregate knowledge. And
Exactly.
aggregate knowledge really is always better than individual judgment. Of course, you still need to have individual judgment. You still need to have people that you have confidence in who are doing your care. But it's good to know, I think, from a patient perspective, and I think from a care team perspective, that we're all working with the same data, and that we're all making decisions on the basis of known probabilities. And I think here again, AI can be very helpful.
Yeah. No, that's certainly sort of checks out from my perspective as well. And I think that standardization, I think, was really one of the key unlocks in some of the stroke workflow augmentations that we conducted, 6 years ago, and really sort of drove enhanced patient outcomes. So we're very hopeful that oncology, there are similar opportunities there where we can really drive, move the needle with regards to patient outcomes. So very appreciative of that perspective. I wanted to start to sort of wrap this up in some respect. I wanted to talk about the challenges. I know we've spoken about perhaps some skepticism. Maybe it's there, maybe it's not, dependent on the type of sensor. But what do you see as sort of the biggest barriers to AI adoption within oncology more broadly? Are there other issues like data integration or perhaps reimbursement? Are those, equally significant? Like what do you feel are the biggest barriers to really get this moving in the right direction?
It's siloization and balkanization within healthcare organizations.
Yeah,
It's if you come out with a new computational tool and you roll it out and you go to the IT department of a hospital and says, "Hey, I want you to do additional work to roll out this computational tool," and the IT department's first answer is going to be, "Why? That sounds like a lot. That sounds like a lot of work. And how much is that going to cost out of my budget to make this happen?" And at the same time, if you go to the medical legal department of a hospital, they'll say, "Well, we're insane for not rolling this out to detect pulmonary nodules because look at all the uh, payment settlements that we made in the last year for undetected lung cancer." And then you go to the clinicians and you'll get some response in between. And the problem is that everybody has to work together, and we have to decide whose budget is the cost going to fall under, and where's the benefit going to come from, and who's going to own the work, who's going to own the human capital, uh,
right.
and the human labor that's actually going to be required to actually take advantage of the technology. Because oftentimes these things do require some human to actually interpret and follow up in. So I
Mm,
think the big problem is not reimbursement, because the business case is actually a pretty easy business case.
right,
But it's not always an easy business case within your business unit. Uh,
right.
and maybe a unique feature of American healthcare. I don't know if you have those kinds of problems in the UK.
Well, I think it's interesting because obviously we're talking about care coordination for patients, but from a technology perspective, it's almost like provider coordination that you need to do before you can even get to the care coordination to actually address and bridge some of these silos. And yes, I think siloed workflows are definitely very much present in the UK as they are in the US. But I think it's very interesting. I think it's almost when you're a digital health company making a case for the adoption of a new technology, you almost proactively need to address the concerns of that multi-stakeholder group that you're going to need to engage in order to actually execute and implement the technology. Fascinating. I think that is actually, to your point, a very significant challenge, and I think one that it will be on the top of mind for a lot of innovative companies in that space. So maybe looking forward, I would love to understand, if you had a crystal ball, for example, where do you think AI will have the most transformative impact in oncology in the next 5 to 10 years? What are sort of what do you think is feasible and realistic, and also perhaps like what is on your wish list of things that you wish that technology could solve in the future?
Well, I think we can begin with most likely, and I think most likely is that uh, the solitary pulmonary nodule detection and follow-up. I think that's something that's going to be universal. I think any organization is going to be crazy not to have some kind of solution for this problem. And the same is going to be true in the screening setting and following up screening. You know, one of the things that we've done in the United States is we've put a lot of burden of screening on family physicians.
Mm,
And I think the outcome of that has been that they spend a lot of their time doing screening work, and they spend a lot of their time doing public health work, vaccinations, and things like that. And it doesn't give them and leave them very much time to actually take care of patient complaints and problems and symptoms, and actually provide the kind of primary health care most people actually want. So I really think screening needs to be community-based, and I think these AI tools can really help us make sure that we offer community-based screening to our population. I mean,
Hmm.
wouldn't ideally the situation be that, um, if you've got cigarette purchases on your Visa card, that you get a little flyer saying that you should get lung cancer screening at some point, or have a discussion about lung cancer screening, and be able to do that without the need to make it very complicated, go to your physician first. You should be able to just go get that.
Yeah.
And I think there's a place for that sort of community-based screening, and I think AI can help us make sure that we're targeting the right populations. Um, Moving forward beyond that, I'd like to see AI give us a little bit more predictive ability to get the right drugs to the right patients. Um, we in medicine are limited in that, we're all humans and we have a limited ability to customize things for patients. If you're out there and you're a community doctor and you're taking care of 60 different types of cancer, and a patient comes in and they've got a lung cancer, I think it's very hard for them to say, oh, well, let me look at this next generation sequencing panel and actually decide which of the 10 available regimens that I could use as first line therapy would really be optimal, and would really provide them with um, uh, the best chance of survival. And at the same time, what is my adverse event probability with
Yeah.
each of the different regimens available? And can we have a discussion with the patient where we can provide them risk information on a quantitative basis as opposed to just a qualitative basis?
And maybe on a personalized basis as well, that where it can not just say, the risk of you having an interstitial lung, disease or sort of a pneumonitis event with this particular, CDK4, this is because you're a smoker, because you have a background of this, it's actually slightly higher, and actually go that level more to
Yeah.
make the personalized medicine dream a little bit more realistic.
No, wouldn't it be great if we could hand all the patients a tear sheet and it said, here are the 10 available regimens that I can use for you. Here are the probability outcomes with each of the 10 regimens on the standpoint of efficacy. Here are the probability outcomes personalized to you on
Yeah.
those 10 regimens from the standpoint of toxicity. This is the menu of available options. This is the risk. This is how I would order things on the basis of efficacy. This is where I would order things on the basis of toxicity. Where do you want to choose on this menu? Do you want to go for the highest efficacy?
Right.
Obviously, you'd want the highest efficacy with the lowest toxicity, but oftentimes those things are paired.
Yeah.
And so you could provide that sort of thing with an AI solution for patients, in a way that, a brief conversation in the office with an oncologist where they just say, my gestalt is this is the best one for you, and this is the one that works in our workflow best, um, can provide for you. So I really do think that idea of individual prognostication
Yeah.
uh, is something that the future of AI is likely to give cancer patients.
Yeah, I couldn't agree more. It's the thing that excites me the most is we sit in this world with, vast amounts of data. I think it was yesterday I read an article by Eric Topol, one of the one of the leaders in the AI space, Dr. Topol, and it was talking about the conventional CBC, right? The conventional complete blood count. And it was saying, even in the complete blood count, something that's been around for yonks, for decades, there's still a level of personalization which can be incredibly predictive of future events of a variety of conditions. And if we just applied, some relatively simple AI algorithms to that, we could actually deliver much better, much more personalized care to folks. And there's a vast amount of it just sitting in the system. So I imagine similar analogies apply to oncology. And I agree with you. I think AI is perfectly suited to perhaps address some of those challenges.
Yeah. So I'm going to disagree slightly with the way Dr. Topol expressed that.
Okay, yeah, tell me.
The data on the CBC is not incredibly predictive of anything. It's in
Right.
fact minimally predictive. But
Okay.
the fact is that there are 200 other data elements that are also minimally predictive. And when
Yes.
add up all the minimally predictive data elements that are present in the electronic medical record, now we have something that's tremendously predictive.
Yes, correct. No, I think that's a very valid correction. I totally agree. Um, but I mean, regardless, it's these small studies or these small insights where you're right, you get a snippet of what is potentially possible. And to your point, if you can actually aggregate that in some ways and have lots of these different things, actually talking to each other and coming up with a composite predictor, that is, yeah, tremendously exciting. I wanted to ask you a quick question on screening, because I know you mentioned screening as like an area where, which is realistic, and, shifting that to the community and boosting that. What is your view on why screening rates are so low? I mean, I was reading something not too long ago. It's like, 1 in 15 patients or eligible patients was actually attending screening events. Like, what's your view on that? Because that's obviously a huge limiting factor.
Well, this is also a place where AI can help us tremendously, because one of the things that needs to happen in order for an order for lung cancer screening to occur is Medicare requires a risk-benefit discussion with the patient. And of course, these individual risk-benefit discussions have value to the patient to decide if they really want to do it or not. But this almost seems like perfect material to actually be done by a chatbot, as opposed to a human,
Right.
where that risk-benefit calculation can be done, it can be individualized, it can be provided for the patient. And then at the end, they can ask the question, yes, no, do you want to proceed with screening? And if the answer is yes, here's where you can now go. Um, I think every patient deserves a risk-benefit discussion for just about everything we do in medicine.
Hmm.
But I don't know that we need to necessarily pay a six-figure employee 15 minutes of time to have that risk-benefit discussion. I think much of this can actually be personalized and can be personalized with the use of AI and other computer-driven technologies. And that's really what we need if we want to move screening and a lot of other public health interventions from being this bespoke, one at a time thing that we do in American healthcare. And people love bespoke, one at a time healthcare, but we really want to build efficiencies where we can make these things be applied on a population level. Where we can have, one CT scanner sitting in a van going from neighborhood to neighborhood, where everybody in the neighborhood who was potentially a candidate for screening was already evaluated, given a risk-benefit discussion, told when the van was going to be in their neighborhood, and given a potential appointment time. And we're having that van, churn through patients every 5 minutes to do those screening evaluations, getting the information analyzed by an AI, and then getting that risk stratification sent back to them, the information provided to their primary care physician, and all this done in a seamless, well done, coordinated fashion, as opposed to what happens now, which is what happens now is, well, I want to go see my primary care physician, but the next appointment's not available for another 6 months. So then I go and I see the patient, and I've got medication refills that he's got to do, and I've got other things that I want to talk about because my shoulder's hurting and these sorts of things. And the things like lung cancer screening just get moved down to the bottom of that list.
Yeah. Yeah, absolutely. I feel there is a common theme throughout this conversation, which is blinkers, as we say in the UK. It's those, you focus on what's in front of you at a particular point in time, and, seeing that sort of broader picture and being able to look at the broader list of priorities it can be really challenging, especially when you're so busy.
Well, I give the lecture on lung cancer on cancer screening in general to my patient population. And we always start off with a patient vignette. And of course, my patient is not someone who comes in asking for cancer screening. My patient is someone who comes in with back pain.
Right.
Because we need to teach our students that cancer screening patients don't actually come in asking for cancer screening. And that's why we really need to move cancer screening from this idea that, well, we somehow have to tack it on to the end of an office visit for a problem that the patient cares about. And we really got to move it into the community, and we've got to move it to patients in a way that doesn't create too much of a burden on them and doesn't strain our already overcommitted primary care system.
Absolutely. Absolutely. Dr. Nieva, I want to be respectful of your time. This has been an enlightening conversation from my end. I guess, is there anything else you'd like to share about AI in oncology, or any advice for those, like Viz.ai, like other healthcare sort of providers working to innovate in this space? Is there anything you would share, any insights that you would like to share?
The only thing is that everything is based on data. Get the data, get the biggest data that you can as you're putting together these systems, and then think about clinical implementation early, and think about exactly which clinical decision you're going to influence with your product. And in the case of Viz.ai, I think the focus on pulmonary nodules has been a very good one. I think it's been a very important one for the company. But every single question that you ask has to be this very discrete, single clinical question and trying to come up with an answer. Nobody can boil the ocean, but everybody
Right.
can certainly answer one question using large data sets and come to the right answer most of the time.
Absolutely. Well, look, thank you so much for your time and your insights. It's been an absolute pleasure speaking with you today. Thank you so much.
Delightful talking to you, Dr. Manley.